All right, let's see how we go. We'll just wait a bit longer. Hopefully, Mara's managed to get the computer working.
I think, Trish, actually, the time, as far as the time frame is concerned, it's yours and it's all very similar, isn't it? As far as the cancer pathway is concerned, really.
I would have thought so. Yeah, I mean, sort of 24, 48 hours for contact, unless we're on leave. But I don't know from your point of view, because there's a couple of other people in your team, but here I'm by myself, so.
Yeah, we do try and do that. You're right, between 24, 48 hours. Somebody normally contacts the patient within that time frame. Yeah.
Sounds good.
I've managed to get in touch with Suvan, and they said they're setting up. They're nearly there. Oh, sorry about the delay.
Good. That's all right. Thanks a lot, Myra. Let me go to the. Should I go back to the screen? I don't know. I mean, you've got the questions ready, Anita. So if there's anything there that is more that you want, because the other thing I was going to do with this, Anita, was the video recording will be available. So if for some reason you get another department asking similar kind of questions, then, well, technically you could say this, have a look at this video. We'll put it onto the trust. We have a private, educational YouTube channel.
Yeah.
All right. Okay.
So we could share the link in the future. So if you get questions from people saying how, from say nurses on the ward saying we've got this problem, it's a new cancer, you could say, well, if you want to have a look at this educational video, that saves you time with answering all those questions.
Yeah, good plan.
Well, you know me, try to do something once in a while.
Of course.
Hi, Anita.
Hello.
Hi, I'm just wondering, could you add in the question as well? Because I remember when we were discharging one of the patients, they were asking about their medications and multivitamins. What is the best answer to that as well?
Yeah, certainly. I mean, I can answer that now if you want, or are we not?
We'll wait for everyone to come and then then.
Okay, thank you.
In the let's see. Hopefully they've got the TV running in a second.
Oops, I think they're hopefully here.
Can you see them? Let's see.
I'm not fond of my face being on here at the moment.
Oh, yeah, I don't know why yours has come. Oh, is it because of your letters? You can phase it out for a sec. I don't know how to put my face in my big ugly face over there.
I don't know how to do these things.
Oh wait, I can do it. Spotlight me. Let me see.
Spotlight
you highlight your video. What does that mean? I have no idea what that means basically. Spotlight me. Yeah. Microsoft Teams has got a lot of different options now.
I haven't got a camera, so I can't put my face up anyway.
Lucky you. Lucky you.
You can turn
we do have your face, Anita.
Yeah, you have your picture.
Yeah, that's good. That's good enough.
That's what you got to do, Trish.
Oh, there
Hi,
you
Robin.
are. Well done. Hi, Robin. Morning.
Good morning.
I think his microphone's on mute still, but hopefully he can hear us.
Yeah, now we can hear you.
Oh, morning. Well done.
Yeah, no.
Is everyone ready on your side?
Yeah, I think so. Yeah.
All right. Good morning, everybody. So thanks for joining us. We have two wonderful guests with us today. We've got Trish, who's our upper GI CNS, and I'm sure you also know Anita, who's does the lower GI section. And they both kindly offered their time so that we can do a teaching session about dealing with cancer in endoscopy, which I think is actually very pertinent for a lot of us. So really, this was a really good idea that Sarah came up with, because I think you guys deal with a lot of new cancer diagnosis, and a lot of tricky questions come about, like patients ask about how long before they're spoken to and they have tests, who makes the contact, how do you break bad news and things like that. So hopefully over the next 15 to 20 minutes, we can answer some of those questions with Trish and Anita, so that number one, you are well informed about what you need to do. And also it helps with understanding the expectations between what the CNSs can do too. So there's no confusion for the patient, because the last thing you want is a confused patient who's just been given some really bad news, and it is very stressful for them. So we know that. So Trish, Anita, you know, the floor is yours. We can play it. It's quite a free and easy format. I think you know, we can start with, I guess, anything you want to say first, and then we can talk about timeframes first, I suppose.
Okay, so I think one of the things for me is upper GI is that I just wanted to let you know that in days of old, when Gerard was around, he probably broke bad news to all of the patients in the department. Well, things have changed since then, and the workload is significant and massive. And I don't have the luxury of spending all of that time with you guys now. The demands on my time are elsewhere. Our caseload, or my caseload, is probably about 150 to 160 new patients each year, plus the existing patients. So it does make it quite difficult to be in multiple places at once. So I apologise if I don't manage to get or be there for the breaking bad news. And I think it's realistic to say that I probably won't do on most occasions. So
from my point of view as well, Trish, I think as a similar situation to you, although obviously there are more than one members, I am the only full-time member of staff actually on this site, and we also have 7 consultants that we look after, and their clinics, and they're breaking bad news in their clinics as well. So it's similar to you in that we simply don't, there's only so many of us around. And although, like you say, in an ideal world, we would love to be able to come and see every single patient. The other fact is also, now that you're seeing patients over weekends, we get quite a few patients picked up with their cancer diagnosis over a weekend, and obviously we aren't here then. So we will come if we can possibly come, but obviously that's why we're doing this session, so that we can give you a few pointers when we're not able to be there.
Is that okay?
Yeah, no, I think that makes a lot of sense, because sometimes there's this weird expectation that oh gosh, this patient's got cancer, let's call Trish, let's call Anita, they're gonna get here straight away, let's leave everything, let them sort it out. And that's not the reality anymore. We've got to make sure we do things in the right way, so that people get the right kind of information.
Yeah. So from the GI point of view, contact I aim to make within 24 to 48 hours, unless I'm on annual leave. So generally you'll know from my phone message on my mobile or my email that where I am. It always will say that I'm on a day off. So my day off is always a Monday, unless it was like a bank holiday, and then I will probably be off on the Tuesday like I was this week. But annual leave, there is no cover. It is just me.
So as far,
go ahead, sorry.
I was going to say, so as far as the lower GI, yeah, we have got the luxury. We do try and cover each other, because there is more than one of us in the lower GI team. However, as I said, we also cover multiple clinics across sites as well. So if we aren't able to come, then we will also try and contact the patients in the same time frame, about 24 to 48 hours after they've been diagnosed, or almost diagnosed, in endoscopy.
Thank you. That's useful, guys. Those of you at the unit, any questions about that? Robin, anyone else?
No, we kind of expect, we know they're really busy, so it's normally the endoscopist who we expect to break the bad news anyway. But you know, if the CNSs can turn up, all the better.
Yeah.
But
yeah, I agree with you, Robin.
Yeah, it is. It's nice to be able to start making the relationship at that point, but it, you know,
doesn't always happen. Yeah. Anita and Trish, just a quick question. On the weekend, what is your preferable mode of contact when we report to you that there is a case? Would you rather, I thought Anita said email is preferable than leaving a message? Yeah.
Yeah, I think email is grand, because sometimes I don't check the phone straight away in the morning because of picking up emails and stuff. So I'm tending to do emails first, so that's preferable for me.
Okay.
Yeah, I think so for us as well, mainly because of the fact that, as I'm sure you're all aware, the phones have not been the best in the world recently.
True, yeah.
So we've lost quite a few of our phone messages, and I am desperately worried that we're going to lose somebody from endoscopy. So yeah, emails is good for us as well, actually.
Is it directly to your email address, or is it to a generic one that's preferable?
It's a single for me, so trish.easton@nhs.net.
Yeah, any of us really. Like I say, I'm here full time, so probably I'm one of the better ones. Or our support worker Amanda is also very good at picking up emails because she's the other full time in our team. I don't know whether you've got her email address, but I can drop a card round to you later.
Okay, thank you so much.
So the other question was CT scans, and we normally get those done within 2 weeks because the patient is on the cancer pathway. It's often quicker, especially now COVID is easing, so that tends to be a little bit faster now, and also they're doing over the weekends and stuff. If once you email us, if there is any possibility that you can let Charlotte Hughes know, who's our patient pathway coordinator, she can sometimes chase it up as well. So that's another good way of speeding up the process for the patient.
Yeah, our time frame's the same as you say, because the patients are going to be on the cancer pathway. They usually get their scans within 2 weeks. It's very rare that doesn't happen, in fact, actually. So that could, that's what is expected, and so you can tell the patients that.
Sounds good.
Can I ask a question?
Yeah.
Go ahead.
So yesterday we had a lower who had a possible cancer, and he lives alone and he's not got a phone. And we tried to get a CNS to see him yesterday, and they wasn't available. So what happens with him?
So he's not got a phone?
No.
Well, that's a bit of a rare one, isn't it? Gosh.
Yeah,
definitely.
So if he's for me, then I'll write him a letter introducing myself.
Lower.
Oh, he's low.
But in your carry on, Trish. Sorry.
Yeah, I think I would write him a letter and invite him to a face-to-face.
Yeah, I think that's probably what we would do as well. That's extremely rare.
Yeah, it's very rare. I mean, it's strange in this day and time for someone to have no phone or even an email.
He was an older man.
Okay. But I got to say, a lot of my 88-year-olds still have a phone, but everyone's different, and some of them don't like technology. And in that case, unfortunately, we have to do it the old-fashioned style, which is get a letter to them straight away and get a face-to-face with them.
Yeah.
But yeah, and he had no family either. Sorry.
So I was going to say, I'll pick that one up then, Cindy, today.
Okay.
I have emailed you the details, Anita.
Yes, thanks, Robin. I've got about 1 million.
Okay.
And that's the thing we have to remember, actually. Our CNSs are under a massive explosion of cases, so we have to keep that in mind. I think like I said, it's about managing expectations.
I think the other thing also is, talking about our roles and things, we do also look after some of the oncology patients as well. So a lot of the patients that come through us are not just being diagnosed and going to surgery. So there are lots of other avenues that our patients are going down that we have to also keep track of. So like I say, endoscopy is one very small element of the job that we do, actually.
Yeah.
I think it's really important to put that into context, actually, isn't it, Anita? One of the questions here is, should we advise the patient to make contact with you or await your contact?
I mean, from my point of view, I don't mind either, because if they've got questions and they're really desperate, then let them phone me. Some people like things to sink in before talking, so that's fine, but it really depends on their anxiety level. And if you pick up that they're really anxious, then flag that up in the email to me and say that, you know, they're not the sort of person that's going to wait. So I have no problem either way.
Yeah, agreed. Exactly the same. It's all down to the patient's preference, really. Some patients, like you say, want to go away and think about it and just get their head around it before anybody contacts them, and other patients really want you to make contact with them straight away. So I'm quite happy for patients to call me anytime.
Yeah.
Thank you. They're asking about some general principles of breaking bad news. Any tips on dealing with common responses? This is it's a tricky one because there's so much. Actually, you could do a whole session on breaking bad news.
Yeah.
So I don't know, Anita and Trish, do you have is there any links to, I don't know, the Cancer Network? Any good website or video that helps with that too?
There probably are lots of on the palliative care, and I'm sure I've got some teaching sessions that that I've got overheads for, so I can fire off those to you guys. But I think, which I will do, but my principles are always sort of establish the patient's understanding first. You know, the reason why they've been referred, work out, because my discovery is often the GPs are not telling these patients why they've been referred so fast.
Agreed. Yeah.
And always double check whether or not they want somebody there. And often if you're going through what did the GP say, that sort of is starting the warning shot, if you like. Identify the symptom that they presented with, the pain, the dysphagia, the bowel problems, you know, whatever, and then explain the findings clearly. Don't flim flam. But my key thing that I learned the hard way on is don't ever say it's a definite cancer.
Yeah, I agree. I've learned the same lesson.
Absolutely. I can't stress that enough because I've been caught out so many times before, more often than I like to think, actually.
Yeah, always say it's a suspicion. And
I think, sorry to interrupt you, Trish, but I think the cancer word should be used because otherwise people really are, you know, they need to know that it could be.
Yes.
Not that it definitely is, but it could be a cancer. We do need to use that word because otherwise people are just all over the place.
Yeah. Agree. Completely agree, Anita. And then I think explain the process of the MDM, and Anita will explain their process, but ours is always combining the CT, the histology and the OGD information, and that gets discussed with the whole team, and then to establish the best course of action.
Yeah,
and I can go into that in more detail, you know, if you want me to. So
I think everything you said, Trish, is absolutely what I do. Some tips from myself is, if you see someone who does breaking bad news well, I would say please sit in when they do it to see what skills or tips, the techniques they use. I use everything Trish says. I always find out what they know first.
Yeah.
I send a warning shot. My warning shot gambit is, we found some things and some of this news might be difficult to hear, but you know, different doctors use a variety of different warning shots. That's fine, but it's the principle. And just like they said, I say this is highly suspicious for cancer, but I've been caught out before. We should wait for the other results and biopsies before we say so, because the second you say this is definitely a cancer, it's so hard to retract it if the biopsies are not conclusive. So you must remember that even though there's a good chance it's cancer, 10% of the time you get caught out, and the patient, that 10% of patients are really pissed off with you.
Yeah.
So don't say
mildly.
something you can't retract later. It's a good principle, but you still have to be clear. So it's that balance between clarity but not putting your foot in it too much.
Yeah.
I was going to say the other thing also, I think for the patients that's important is, although even if we can't actually be there physically, is for you to reassure them if you're talking to the patients that actually that we will be, there is somebody that they can contact, there is somebody that is there looking after them, taking them down the pathway and making sure that things are going to go the right way.
Yeah.
Because I don't, I hate to think patients go away feeling completely desolate and then have no one that they can contact or don't know who to contact. That's really important to me.
Yeah.
I always say to them, you're not alone, and it is an important thing to mention. They do sometimes see the word Macmillan and get a little bit panicky, so that's an interesting one. What do you guys think about that?
I'm going to get some new cards because the only ones that we get are from Macmillan. So I'm going to get some new cards printed that are not from Macmillan, so that they don't have all of that trademarking and everything on the back. So that should hopefully solve your problem there.
I mean, traditionally we always gave out cards without Macmillan on them, but we've been having difficulty getting hold of those. In fact, actually, because we used to print them ourselves, but of course they've changed all the printing system, so it's a bit difficult to print our own cards now. However, I think that's right. We can certainly do the same thing. Like I say, we never used to give the Macmillan cards out. However, I think also it's worth knowing that explaining to the patients that although it's got Macmillan on it, it doesn't necessarily mean, it just means that we're going to be taking them through the process and that we are sponsored by Macmillan to do that thing, rather than actually you've definitely got cancer because we're giving you a Macmillan nurse. Do you see what I mean? Does that make sense?
Yeah. I think it's explanation saying the name itself doesn't mean, because a lot of people associate it purely with palliative and they're dying, but actually it's more than that. I think that's one thing for endoscopy nurses to know is being clear. Just say it's got the word Macmillan, but that doesn't suddenly mean this is the end of the world. It's just a term used to describe a broad kind of job description, really. Any questions from the endoscopy side? I mean, we've gone through quite a lot of material there. Robin, anyone else? Any questions?
I just want to mention something. I would love one day just to attend MDM meeting so that we can see how the surgeons and the
I think that's a great idea. Friday morning is the upper GI cancer MDM, which is 8:30 to 9:30 if we're lucky. It runs for an hour rather than 2. Anita, yours is on Friday afternoon, isn't it?
Unfortunately, yes. So that can run very late. It's right pain, to be honest with you, the worst time of the week. Only because the fact
that if you want if you want maybe so anyone else, if you let me know in advance, my office has 2 desks, so you can always sit in I would say 1 volunteer at a time to see what it looks like. I'm more than happy for you guys to observe, actually, because I think that gives you a better perspective.
Thank you, Dr. Fong.
I wonder if anyone would like to come to an oncology clinic as well to see the other end.
Yeah, that's a good idea.
Yes, Trish, that will be very good because I totally support that. That's what we've been trying to do. We're trying to, as much as possible, have everyone, be knowledgeable with everything that's going on related to endoscopy. So that would be really, really good.
Yeah, they're Friday afternoons. Friday afternoons from 1 o'clock. We see new patients at the beginning. So again, you'll see the Breaking Bad News process kind of reiterated, and because we talk about prognosis and all of those kind of things and why people have gone down the chemo route or chemo rad rather than surgery and stuff like that. So that'll expand knowledge as to the processes from endoscopy.
And like I say, from our point of view, it's Friday mornings. So Friday mornings we have 2 oncology clinics, and also we have a nurse-led oncology clinic for the patients that are actually on chemotherapy at the moment. And Caroline Bishop, one of our nurses, she does that, and I'm sure she'd be very happy to have somebody come and sit in with her. It's a telephone clinic that she does normally, but just to explain what she's doing and the principles of the chemotherapy that the patients are on and why they're on it and that sort of thing, because they do adjuvant chemotherapy as well as the treating type.
Thank you. Especially now there's no more Breaking Bad News training from the trust.
Oh,
we couldn't
Really?
get hold
Oh,
of any training anymore. Yeah,
really?
it used to run quite regularly in the past.
mm,
But we haven't had any in the last, well, suppose
We
because
should
of the
look into that.
pandemic.
If not, actually, what I suggest, Myra, is we do
Yeah.
another endoscopy session, nurse session on Breaking Bad News. I think that's a great
Oh yeah,
idea.
that would be
mm.
great. Yeah, yeah. Thank you.
All right.
Thank you.
Myra, was she there?
Yes.
The hospices used to run palliative care Breaking Bad Newses as well, didn't they? You used to be able to go and access the hospices. I don't know if you can do
Yes.
that.
Yeah.
It was advanced communication training, wasn't it?
Yeah, because I've done that through the hospice. So I don't know if you can access
Yeah, we can look into that as well. Yeah.
Yeah.
We should look into that. I think
Yeah.
being trained to do Breaking Bad News well is a really core skill. I can't stress it enough, actually. It takes away so much distress and if it's done properly. I personally think it's an even more core skill than being able to do endoscopy. You need to know how to do it properly. Yeah.
True.
Okay.
Yeah.
We've got a few more questions before the session ends. There's one about what tests should we be requesting for you guys, like any particular bloods and whether they should have any medications changed. So I don't know whether Trish, you want to go from your side first and then Anita.
I mean, that's a difficult one because we don't necessarily until we know whether or not anybody has got a definite diagnosis, we wouldn't necessarily go ahead and do any of their pre-tests, blood tests for chemotherapy. So it would kind of be a bit preemptive, really.
I think, but if they probably haven't had like basic bloods for the past year or something, you'd probably
Yes.
it'd be reasonable to do like routine bloods if there's nothing in the last 6 months. I think it'd be very low likelihood that was the case anyway. But would you say that's a sensible suggestion?
Yes, for sure.
Yes, absolutely. And from my point of view, actually, it's really an advantage if we can do a tumour marker. So for us, for the lower GI, it's a CEA. It just gives us a baseline, in case.
GI CEA would be helpful.
Yes.
And staging CT requests is obviously something. It'd be preferable if the endoscopist can request a CT chest abdo pelvis, isn't it?
Yeah. Yeah, perfect. Yeah, and that happens actually. I will say it doesn't not.
Very rare. Can't remember the
This is
last
quite
time.
rare, but you sometimes it's good to be clear because you could have a locum or someone who doesn't know the system, and that's important for the nurses to remind them. Any other tests, or you think that's roughly what that's probably the kind of standard, isn't it? I wouldn't get too complicated. Medications, do you guys have I don't think in upper GI we do any crazy medication changes, but do you guys advise any particular changes once they get diagnosed?
No, in fact, actually, as far as the lower GI is, we encourage them to continue with all their medications that they're on, in fact, actually. And then if things need to be changed over time, we can do that. But as it stands at the sort of endoscopy stage, no, they would just continue with everything that they're on. And obviously, if they're on blood thinners and things, they follow the advice after they've had the procedure. So, yeah.
Thank you. I think we've nearly covered everything. The last question is a very, very thoughtful one, and it's the hardest one sometimes to answer. Any general guidance how we can be helpful and compassionate? I would say from my perspective, the more you can think about what your patient is going through, it's easier for you to learn to try to want to help minimize their suffering. So compassion really means you want to take away that patient's suffering, and the best way is try imagine what you'd be feeling in the same situation. Now, if you're not mentally ready for that, then maybe it's not the best time to break bad news. But if you are strong enough for that, then that's one way I try imagine what's going on in their head, and that makes it easier for me to try to help them and explain things.
Yeah, I agree. I think we all know that every patient is individual. Everybody reacts slightly differently to the news that they're being given. But I think from my point of view, as I said before, just reassuring the patients that they've got somebody that they can contact is a really good thing to do, even if we can't be there at the time, because it just means that they've got a lifeline. And I think that's what most people want when they've been given sort of, the possible worst news that they could ever be given as far as they're concerned. So from my point of view, as far as the endoscopy staff are concerned, if you can just reassure your patients that we will be in touch or they can get into contact with us and that we are there for them, really.
And I always tell patients that over the next few days, while they're waiting for things to come, is to write down any questions that they've got, no matter how silly they think they are, and then discuss them with you.
Yeah.
Very good idea.
Yeah, I think that's a great idea.
That's
Great
good,
idea.
Dawn.
Yeah, very much so.
Because you might go some blank when you hear that diagnosis.
Completely.
Agree.
Completely.
Agree.
Okay.
There's-
Now, I think we're reaching 8:30. Oh, go ahead, Annie.
If there's anyone that you pick up from my aspect who's got really bad swallow difficulties and they've lost weight and you're thinking, I'm not sure how this is going to go, refer to the dietitian, absolutely, the community dietitian, or speak to one of the consultants about whether or not you think they're actually going to be able to wait about stenting or even something like that if you're really worried about their level of consumption of calories and fluids.
And from my point of view, if you find somebody that's got a lesion that you can't even get a scope through, then it's really important that they're given a low residue diet actually, and that they are also given the symptoms of obstruction, so they know that they need, when they need, if they need to come into hospital if it's really tight. The other thing is we've got low residue diets. I don't know whether you've got any down in endoscopy, but we've got one that's been developed by the dietitians actually. So I'll bring some down. I think you have got some, but I need to make sure you've got the right ones.
Thank you, Anita. We do have some.
Okay.
That's great. All right. Well, guys, I think that's running to an end. But sorry, Mara.
Yeah. Just
So,
quickly.
guys,
I think our take from this talk, which is if I cannot stress enough, this has been a very, very good talk from Trish, Anita, and Dr. Fong. Is that we're gonna do a little sort of guideline or guidance for our endoscopy staff and everything that we have discussed today, and then I'll have it checked with Dr. Fong, Anita, and Trish. You know,
Lovely.
including
Thanks, Mara.
bloods,
Thank you,
CT scan, and all of that, and who to contact, what to do next. Yeah.
Sure. I mean, the other thing is also, sorry, I was just going to say, I'm sure Trish will feel the same way, that, you know, if any of you guys have got any questions that you can think of afterwards, you know, we are very approachable. You can always give us a call and ask us.
Yeah.
It's to our advantage as well, you know.
Yeah.
It definitely works
Thank
both
you,
ways. And
Very
I'm
much
really
so.
grateful to everyone who's on today, because I think this is a great session. The video will become available later, and I'll send to Trish and everyone and Anita the link, so that if you ever need it for educational purposes to other groups, then you've got it. So yeah.
Brilliant. Thanks, Stephen.
Yeah, and thank you to Sarah Balch for helping.
Yeah, thank you, Sarah. Really good idea.
Yeah, it's been really good. Thanks, everyone.
Okay.
Thanks.
Thank you, everyone.
Have a good day.
Bye.
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 Bye.